So good morning, everybody. My name is Paul van Schille. I'm a thoracic surgeon from the University of Antwerp in Belgium, and I'm the current president of Wclc. I'm honored to moderate Wclc first press briefing at this meeting, our 2024 World Conference on Lung Cancer. This year, we are also celebrating our 50th anniversary. We have certainly come a very long way since our first conference, and we didn't have any press briefings at that time. 2 housekeeping notes. Please hold all your questions until the end of the briefing, and please remember you can view the press briefing afterwards again on the Wclc YouTube channel later today. We have a lot of topics and grounds to cover in 1 hour, so let's get started. Our first presenter is well known to the lung cancer community, Dr. Charles Rudin of Memorial Sloan Kettering Cancer Center in New York City. Dr. Rudin is Deputy Director, Memorial Sloan Kettering Cancer Center, co-director of the Druckenmiller Center for Lung Cancer Research, and the Sylvia Hessenfield Chair in Lung Cancer Research. Dr. Rudin has led the National Cancer Institute Small Cell Lung Cancer Research Consortium since its inception in 2015. And I should add, he earned the Paul Bunn Junior Scientific Award in 2019 for his lifetime achievement in scientific contributions to thoracic cancer research. This morning, Dr. Rudin will present his findings, ilfinatinib deruxtecan in extensive small cell lung cancer, interim analysis of IDEAT Lung 01 study. Welcome, Dr. Rudin.
Well, thank you, Paul, and I'll start by thanking you for your leadership of the Wclc over the past year. We're thrilled to have you in that role. Today, I'm going to very briefly present the key findings from this study. If a larger presentation will be on the program tomorrow. This is the interim analysis, as Paul said, of IDXD in recurrent extensive stage small cell lung cancer. This is the trial design, and the data that we have to analyze at this meeting are really in the yellow box. It is the randomized portion of this study. Patients enrolled in this study have recurrent metastatic small cell lung cancer between 1 and 3 prior therapies. Patients with asymptomatic brain metastases were allowed to enroll, even untreated. And 2 doses of IDXD were evaluated, 8 and 12 milligram per kilogram. As you may know, this is an antibody drug conjugate directed against CD276 or B7H3. It consists of an IgG1 antibody, a cleavable linker, and a payload, which is a potent topo-1 inhibitor, the deruxtecan warhead. The trial was designed to have about 40 patients per arm, and then based on assessment of outcome between the 8 and 12 milligram doses, a single dose was chosen as the recommended dose for phase 3 testing, and there was an expansion cohort of extended enrollment of about 70 patients in the 3rd line and beyond that have actually accrued, but we don't have data yet on those patients. The primary endpoint of this trial is overall response rate by blinded independent central review. I'll really focus on the primary endpoint and safety today. Additional secondary endpoints will be covered in the talk tomorrow. These are the waterfall plots and the reflection of the primary endpoint of response rate. The response rate, confirmed overall response rate at 8 milligram per kilogram was 26%, about a doubling of that to 54.8% at the 12 milligram per kilogram dose level, as shown here. Disease control rates were excellent actually on both arms. I'll point to the 12 milligram per kilogram dose with a disease control rate of 90%. Really impressive, I think, in the context of recurrent metastatic small cell lung cancer. Safety profile of this agent was manageable, I think, at both dose cohorts. With no real unexpected toxicities, we have a fair bit of experience with antibody-drug conjugates with the deruxtecan payload at this point, and I don't think there were any great surprises here. A little bit longer duration of treatment on the 12 milligram per kilogram arm. Treatment-related adverse events associated grade 3 and above were similar. A little bit higher treatment emergent adverse events associated with drug discontinuation on the 12 milligram per kilogram dose cohort, perhaps related to longer duration of treatment. You can see the primary adverse effect on the right, really focusing on GI toxicity and hematologic toxicity, again, not unexpected in the context of a topo-1 payload. So I'll stop there. Really, in summary, IDXD demonstrates promising efficacy in patients with extensive stage small cell lung cancer. The 12 milligram per kilogram dose in particular had improved efficacy compared to the 8 milligram per kilogram dose, with a doubling of overall response rate to 54.8%. The safety profile was generally manageable and well tolerated. Most common treatment-related emergent adverse events were gastrointestinal and hematologic. And the 12 milligram per kilogram dose has been selected as the monotherapy dose for further clinical development in small cell lung cancer, including a phase 3 trial that has been launched in patients in the second-line setting after one prior therapy. Thank you very much.
Thank you, Dr. Rudin, for this very clear and excellent presentation. So we keep questions until the end after all the presentations. So our second presentation is Deep Multiple Instance Learning Enabled Gene Mutant Prediction of Lung Cancer from Histopathology Images. Will be presented by Professor Wenhua Liang from the China State Key Laboratory of Respiratory Disease and National Clinical Research Center for Respiratory Disease, the first affiliated hospital of Guangzhou Medical University of China. So welcome, Professor Liang. You can start your presentation. It's an important topic, I think.
So thank you for the introduction by Professor Paul. And good morning, ladies and gentlemen. We are honored to introduce a deep learning system to predict multiple gene mutations of lung cancer using histopathology images. I'm Wenhua Liang from the National Center for Respiratory Medicine for China. Accurate detection of driver gene mutations is essential for effective treatment planning and prognosis prediction in lung cancer. The current genomic testing, for example, the NGS, which relies on high-quality tissue samples, is often time-consuming and resource-intensive, limiting its accessibility, particularly in low-resource settings. Addressing this gap, we sought to use the routine acquired histology slice to predict gene mutations. We collected paired pathological images and gene mutation data from 16 centers and 3,600 patients in China, which represents the largest cohort for such purpose to date. Then we developed an advanced annotation-free deep multiple instance learning method to enable multi-gene prediction. The DeepGen model demonstrated performance with an median AUC of 0.338 for large tissue samples from excisional biopsies and 0.891 for small samples from aspiration biopsies in the internal dataset. On the multiple center external validation cohort, the model achieved similar results. The model was further validated with an AUC of 0.874 on the TCGA dataset, showing its effectiveness across diverse racial backgrounds. In addition, DeepGen's ability to predict mutations from primary lesion extended to lymph node metastasis. Importantly, the prediction probability derived by DeepGen can also predict prognosis. To interpret the model, we generate spatial gene mutation maps. The high probability EGFR mutation regions indicated by DeepGen were consistent with the regions indicated by the corresponding immunohistochemistry stains. In summary, the DeepGEM achieved robust and superior predictive performance across various genes despite biopsy types and ethnics. The rapid prediction capabilities of DeepGEM allow for quicker decision-making in treatment, enabling patients with severe symptoms to receive targeted therapies sooner. Furthermore, it presents opportunities for multi-gene mutation detection and precision treatment in underdeveloped areas where genomic testing is unaffordable. Thank you for your attention.
Thank you for this interesting presentation, Professor Yang. Our next abstract is entitled Deciphering Single-Cell Resolved Tumor Microenvironment Profiles Using Spatial Metabolic Mapping, will be presented by Zoom by Dr. Aruta Kulansinghe from Princess Alexandra Hospital in Australia. Dr. Kulansinghe is the clinical OMX group leader at the Fraser Institute at the University of Queensland, Australia. He's the founding scientific director of the Queensland Spatial Biology Centre, Wesley Research Institute, and Dr. Kulansinghe has pioneered spatial transcriptomics using digital spatial profiling approaches in the Asia-Pacific region, contributing to the world's first studies for lung cancer. His research aims to understand the underlying pathobiology by using an integrative multi-omics approach. Good morning, Dr. Kulansinghe. I think you're online now.
I am. Thank you for the invitation. Can you hear me?
Yes, we can hear you very clearly. Thank you.
Okay, wonderful. And you can see my slides too.
Yes, we see the slides.
Okay, brilliant. Thank you for the invitation, and I'll give you a high-level overview of our study, which will be presented later at the World Lung Conference. And so I'm an apology for the meeting, but we do have colleagues at the World Lung Conference. So there's a growing need for predictive biomarkers for checkpoint inhibitor therapy. We know that there are a number of predictive signatures that are used in the space, tumor mutation burden, PD-L1 expression, and so on. And what our lab has really tried to do is to do a deep dive on the tumor microenvironment to profile every cell within the complex tissue architecture. And so why this is important and why we think we can glean this information is because we're getting molecular readout, RNA protein simultaneously with imaging readout. And so this spatially resolved signature provides a better annotation of the tissue composition than measuring it at a bulk level. And so in this study, we looked at about 60 biomarkers with single cell resolution at the proteomics level across 43 lung cancer patients. And the panels consisted of an immune profiling core, an IO sort of module, and we built a custom metabolic panel that allowed us to give functional insights into the tumor microenvironment, which we could overlay with the cell phenotype information. And we've put a number of characteristics from the cohort on the bottom right here. And so this is a high-level overview of that modularized spatial analysis. And so this workflow enables us to look at those biomarkers in space and then resolve where they are in the tissues. And then we can ask sort of associations of that data with clinical outcomes. And so at a gross level, we can start to compare between responders and non-responders to checkpoint inhibitor therapy. This is just looking at all the different cell types, so we can identify this. And at a gross level, we can identify that the percentage of Tregs was increased in the non-responsive group. And we then took that and did what's called a cellular neighborhood analysis, which is taking the proximity of cells next to each other. And we asked the question at a cohort level, what was the enrichment of cellular neighborhoods between responders and non-responders? And you can see in the volcano plot on the right, there seems to be this macrophage mixed tumor phenotype, which is enriched for in the response group. We're now still profiling this using phenotype information alone. And so that we could then identify between two cell types in close proximity. We could ask the question, what was the association of having two cell types next to each other across the whole cohort? And we could see that the proximity of Tregs next to monocytes, HLA-DR positive tumor cells next to macrophages, or Tregs next to CD8s was associated with response or resistance to therapy. And so we developed a deep learning pipeline to overlay pathology annotations of the tissues with our multiplex IF data. And what this allowed us to do was we could subset within every cell type. So for tumor cells, for example, we could subset into 3 different classes based on the metabolic or functional profile of the tumor cells. So you had metabolically active, metabolically dim tumor cells. By the same token, you could look at CD8s and look at the metabolically active CD8s and then the metabolically dim CD8s. And so what we found was that the enzymes against metabolic activity profiled at the protein level appeared to separate out the cohort. So we could see the immune cells on the left here and the tumor cells on the right. And the key takeaway from our study was that we identified 3 major metabolic states: OXPHOS positive, negative, and the third cluster, which was pentose phosphate pathway positive, which is characterized by an increase in ASCT2, a glutamine transporter, as well as NRF2 and G6PD, so glucose sort of uptake marker, which were regulators of the pentose phosphate pathway. And these appeared to have a worse survival on a Kaplan-Meier curve in this cohort. So we could see this metabolically active tumor cell proportion identifying the poor responders in this cohort. And I think I'll end here. Thank you.
Thank you, Dr. Wclc. We'll take questions at the end of all presentations, so please stay online if possible. Our next presenter will be reporting on the results of the long-awaited Wclc survey on biomarker use. You may remember that Dr. Smeltzer presented early data in 2019 in Barcelona about the first Wclc survey on biomarker use. He's here for an update on results from the 2024 Wclc survey on biomarker use. Matthew Smeltzer is an associate professor of epidemiology and biostatistics and university research professor at the University of Memphis School of Public Health. His primary research interests include clinical epidemiology, applied biostatistics, and implementation science in lung cancer and sickle cell disease. He's active in the International Association for the Study of Lung Cancer and currently serves on the Wclc Communications Committee. His lung cancer research focuses on quality of surgical care, molecular testing, staging, and early detection. He also serves as principal investigator for the Tennessee Sickle Cell Disease Surveillance Program, funded by the U.S. Centers for Disease Control and Prevention. Dr. Smeltzer has more than 100 peer-reviewed publications and is an accredited professional statistician of the American Statistical Association. Please, go ahead.
Good morning. As Dr. Schultes spoke about, we did a survey in 2018 where we tried to understand how biomarker testing works around the world, what were the patterns of biomarker testing, primarily aimed at physicians and researchers. And we found that testing at that point in time was suboptimal, and we identified some barriers to optimizing testing, which included cost, lack of quality standards, access awareness, and long turnaround times. A lot has happened since 2018. And there's been a lot of therapeutic advances. And now biomarker testing is relevant for lung cancer patients with early stage disease. So we wanted to try to understand what has improved or not, what has changed since we did the previous survey, and how are things going with biomarker testing for early stage lung cancers around the world. And you'll hear more about the methods tomorrow at the presentation, but we used a mixed methods approach this time, where we first conducted focus groups and in-depth interviews to help inform the survey better and also help us interpret some of the results from the survey. We distributed this in English, French, Japanese, Chinese, Portuguese, and Spanish, and translated to English for analysis. A major takeaway from the focus groups and in-depth interviews, these were conducted with thought leaders across the world. A major takeaway is we've really had a paradigm shift in how we should think about biomarker testing. It's no longer something that's nice to have for patients, but it's really a must-have for every patient with lung cancer. The complex issues, though, around making this happen really vary by region. Some things are pretty universal. Some things are real specific to your practice or your region. But universally, it seems that we still need more awareness on the value of biomarker testing, more education about why it's important, how to do it. Cost is a universal concern, and this is a multifaceted problem that we need to continue to try to solve. And the processes around testing our patients have inefficiencies, and we can't really pinpoint exactly one thing, but sort of the whole system could be working more efficiently. The quantitative survey had 1,677 analytic responses across 90 countries and 14 disciplines. We had 14 specialties that replied to the survey, including medical oncologists, pathologists, thoracic surgeons, pulmonologists, and lots of others. 98% of people that responded believe biomarker testing significantly impacts outcomes for lung cancer, and 91% believe they have a clear understanding of who should be tested. However, when we drilled down and pushed on that a little harder and said, how important do you think it is to perform biomarker testing comprehensively on every patient in both late stage and early stage, we found they only replied 63% for late stage and 29% early stage. We think this may point to a disconnect, and yes, we think it helps people, but we're not quite on board with comprehensive testing for everyone. We asked a repeat question from 2018, which was, do you think more than half of individuals with lung cancer in your country are being tested? Last time that was at 39%, and that went up to 67% this time, which was significantly greater. So there is the perception that things are improving. I think this is good. But 43% said they sometimes or often treat patients prior to receiving the biomarker result. So this is not what we want to happen. And so this shows us that there's still a gap in actually getting those results in the hands of the people that need to make treatment decisions in time. The key barriers, the top 5 barriers remained cost, time, sample quality, access, and awareness. And we asked around cost we asked about some different solutions that respondents thought might work well. And some key solutions that were identified that could potentially help were educating decision makers on cost effectiveness of biomarker testing, working with policymakers to mandate or incentivize full reimbursement, working on innovative cost sharing agreements with diagnostic companies and with payers. And in terms of time, getting it paid for, getting the cost barrier alleviated is great, but we also need to get the tests done in a reasonable amount of time so that we can optimize treatment decisions. And so we ask about why does it take so long to get the results? Although people think the median turnaround time is about 14 working days, there's a lot of variation. There was really no consensus around why it takes so long. So we didn't identify a true bottleneck that people agree on, but people did think there was an opportunity to speed up the time between sample processing and molecular analysis. So this fell out as an area of potential opportunity. We also ask, sometimes the biopsy is insufficient. We can't actually run the test on the biopsy that was received. We ask why that happens, and those who acquire the tissue said the most frequent reason is there's an insufficient amount of tumor cells in the biopsy, followed by poor tissue quality as the second one. We then asked the pathologist why they think this sometimes doesn't work and they have to rebiopsy, and 48% said that insufficient tissue was the most frequent reason that they needed to rebiopsy. So in terms of sample quality, those who acquire the tissue and the pathologist agree that insufficient tumor tissue is still a barrier. We wanted to know which guidelines people use at their institution for biomarker testing. So we asked, and 54% says their institution uses the CAP, ISLC, AMP guidelines. 26% said they weren't aware of any guidelines, and 21% used other guidelines besides those I just referenced. And we ask, is it necessary to educate all patients on biomarker testing, all lung cancer patients? 68% said always necessary, 29% somewhat necessary, and 3% not necessary. In terms of how much additional training clinicians have received around NGS and other forms of biomarker testing, 16% had received no additional training beyond their initial medical training. So what's our path forward? Some solutions that the highest ranked solutions from the survey respondents were implementing testing protocols more broadly, government level interventions, trying to address cost and reimbursement, awareness and education, increasing administrative support and organizational support, make the process work better, and better access and availability. So overall, we found improvements in the perception of testing compared to 2018, but there are still substantial barriers. The barriers seem similar regardless of tumor stage, so we didn't find these big differences between early and late stage that we thought we might, although we do know the process obviously works different. Key solutions to focus on are education, clinical processes, and eliminating bureaucracy and government and payer organizations as much as we can, and increasing funding. So some key ways ISLC is going to try to address some of these barriers. We're going to launch an awareness campaign starting today. So we have flyers of the results. So we're going to start trying to disseminate the results widely. We're going to publish these obviously in a manuscript. We're going to take the regional results to our regional ISLC meetings and look specifically in each region what the results tell us. And currently the CAP, ISLC, and AMP testing guidelines are being updated, so you can look forward to those coming out soon. And in terms of access, there's a separate project taking a deep dive, or there will be a separate project we're planning, taking a deep dive on cost. What does it really mean that cost is a barrier, and how do we help solve that? ISLC and Partners Organization, who also funded this survey, have another project underway, which is a more detailed look at some specific sites to help understand processes around testing more deeply and try to learn from that how can we teach others how to optimize these processes. And finally, around quality, the new Partners Project is developing a consensus recommendation on lung sample quality to try to improve our sample collection. In terms of policy, there's a new committee, Global Policy and Partnerships Committee, ISLC is launching, that's going to take on trying to address some of these policy issues. I'd like to thank all of the survey respondents who took time to provide input, our ISLC Steering Committee and co-authors listed here, and the ISLC Partners for Thoracic Cancer Care. This is a partnership with industry that is funding a lot of important work right now with ISLC. Thank you.
Thank you, Dr. Smeltzer, for this very interesting and provocative data supporting the commitment of ISLC to biomarker testing. So I have more abstract flyers available over here, so please feel free to pick up one at the end of this meeting. So the full presentation will be given tomorrow in session OA 03.03. ISLC prides itself on including patient advocates in virtually all facets of our programs and events, including our press briefings. Today, we are very fortunate to have ISLC patient advocate Dusty Donaldson with us to provide a unique perspective. Dusty Donaldson is founder and executive director of Lifeline, a 501c3 nonprofit serving the lung cancer community. She's also president of the Lung Cancer Action Network, LungCAN, a collaborative association of lung cancer nonprofit organizations and patient advocacy groups. In 2016, she co-authored the book, The ABCs of Lung Cancer for Patients and Advocates, and is now working on the second edition, soon to be released. Dusty has been a reviewer for lung cancer research proposals for ASCO's Conquer Cancer Foundation and the Congressional Directed Medical Research Program's Lung Cancer Research Program. She's a contributing writer for www.lungcancer.net and serves on the National Lung Cancer Roundtable's Survivorship, Stigma and Nihilism Task Group. In 2022, she received the Wclc Patient Advocate Educational Award. Prior to being diagnosed with early-stage lung cancer in 2005, Dusty was a journalist and public relations professional. She earned undergraduate and graduate degrees in journalism. Please, Dusty.
Thank you so much. I just would like to comment briefly. I don't have a slide presentation, but I've been in this space of lung cancer advocacy for later this month, it will be starting my 20th year. And I mean, you guys just really are moving my heart. And I mean, it almost moves me to tears to see this amazing level of progress. And it is just so exciting. Dr. Rudin, your small cell research, we have seen such devastation in the small cell lung cancer community. The standard of care hadn't changed in decades. And what we're on the brink now of not only your research, but other research, and we're seeing patients benefiting from that. It would be a very devastating diagnosis when you get extensive stage small cell, but things are turning. We're really on the brink of amazing things. The biomarker testing research that you're doing, the assessment around the world of who's doing it, who's not, what are the obstacles. These are so incredibly important. I'm just going to share, and I don't want to go too much about it, I just have to share a quick story. A friend of mine who lives in my town in North Carolina, she was given 100 days to live, okay? She had metastases throughout her body. They did the comprehensive biomarker testing, and at that time, there was no treatment available, but it did show that she had the RET mutation. And she had to go through the regular chemotherapy. Now, her doctor gave her 100 days to live. Maybe with the chemotherapy, she could extend it to 120 days. My friend is going on her 7th year now due to the targeted therapy. She has seen her 3 children get married. She now has grandchildren, and as she calls, granddogs. And I mean, the dramatic impact of the biomarker testing and the targeted therapy that gets developed from that, it just cannot be emphasized enough, the impact to the patient community. And sir, what you're doing in China is just amazing as well. It's just incredibly powerful, and I can't find any fault with any of this, but I do want to add one perspective with the predictive analysis. This was my only concern. It's necessary, it's important. We need the predictive analysis to be able to move forward. My concern as a patient advocate would be that as we're predicting these, I mean, I can't imagine that we would be 100% positive of a predictive value. And I just want to be mindful that we're not preventing access to patients because we're saying, well, you have a 79% predictive value that you will not respond to this treatment. So insurance companies, payers may be reluctant to fund something like that. And so I just want to always be mindful that we don't want to, in advancing the science, that we're preventing access to the patients, because I have seen so many people who were not expected to respond, who do respond. And so, but fantastic. I'm so excited about the research. it's at such a high level compared to 10 years ago, 15 years ago, 20 years ago. And as a patient advocate, I am just delighted with everything that's going on. So thank you very much.
Thank you very much, Dusty, for these insightful comments and remarks. It's time for questions now. So please state your name and to whom you address your question, to which presenter. It seems that everything was very clear. Oh, I'm sorry, but I cannot see you.
I look forward to the full discussion in the upcoming days. But really what struck me was what you mentioned at the end, with advancement of all these research, we should also be mindful that we are not closing the doors on some access to patients. It has happened before and it will continue to happen. Many interesting drugs have seen their end because at the end it didn't really work out in a larger population. Dr. Rudin can probably account for that quite well, but it did help a lot of patients. So maybe future research can look into that and make sure that access is not shut down. Thank you.
We have a question from the press. Hold on. This is for Dr. Rudin, from Carolyn Helwick from ASCO Post. Will this drug that you're studying not also work for non-small cell lung cancer because of B7 expression level?
It's certainly possible. So the target CD276 or B7H3 is broadly expressed in tumors. It's not exclusive to small cell lung cancer. We think the first shot on goal here is with small cell lung cancer, but there may be much broader application.
And we have a question from Suzanne Ross from Cancer Discovery News regarding ifinatamab deruxtecan. How will it improve upon current therapy for ES small cell lung cancer? What is the current treatment, and is there any need to test for B7H3 expression levels? Finally, anything surprising to you in these results?
Thank you for the question. So, the treatment for patients with recurrent metastatic lung cancer remains suboptimal, let's say. There certainly is a need for additional drugs in this space. We think this is a highly active agent with a high response rate. So I think it has a clear potential path forward for benefiting patients with recurrent metastatic extensive stage small cell lung cancer. The surprising thing to me, if I can comment, we've done a fair number of trials following this Project Optimus strategy of randomizing doses, and many of those haven't really clearly defined a preferable dose. This one really does. It's a doubling of response rate between 8 and 12 milligram per kilogram. I have to say I was somewhat surprised by the difference observed between the doses and the clear preference among the steering committee members for the 12 milligram per kilogram dose going forward.
Thank you, Dr. Rudin. Are there any other questions? Hold on a sec.
Hi, morning. Jose Corona from the National Cancer Institute from Mexico for Dr. Smeltzer. Very interesting results. I'm a thoracic surgeon, so it comes to my mind thinking about the 29% of people thinking it's important for early stage patients molecular testing. What do you think about it?
Yeah, I think that is concerning, and that was 29% said highly important. So we would like everyone to think it's highly important. I think. So that means that we probably need to get the message out better about especially EGFR and ALK, especially for surgical patients. So yeah, it definitely shows that there's work to do, and the gap I think is important between the two, that people still don't quite value it nearly as much in early stage. So I think it's probably an awareness issue at this point.
Thank you.
We do have another question from Carolyn Helwick from ASCO Post. This is for Dr. Kulaseng. Carolyn's asked, you presented a lot of data. What are your top findings? Perhaps you could summarize those again for us. Thanks, Carolyn.
Yep, that's a question. Our major findings from the study was that the cell typing information wasn't sufficient to give us sort of deeper insights into response and resistance across that cohort, but the lens of metabolic activity within the individual cell types were associated with a worse outcome. And so being able to functionally profile the tumor cells for these metabolic markers, we think was a really important finding, and we think we're working to validate a lot of that moving forward. It seems like these tumor cells are adapting under the pressures of therapy, and that's what we're trying to profile in these samples. And it's linked to this sort of Warburg effect in the tissues, and this metabolic activity appears to be associated with the resistant phenotype.
Any other questions in the audience? Okay, thank you for coming.
I have a question for Dr. Liang Wenyo. I thought you hadn't any questions, so I will ask you one. How to deal with heterogeneity within a tumor, or did you have any comparisons between the biopsies and final surgical specimens to see whether there is anything discordant?
Okay, thank you, Dr. Paul. It's a very good question. So actually, we predict the mutations by using the whole slice of the tissue sample. So we have tested, compare which part of the slice we are using to predict. So we found that there is they all contributed to both the tissue the cancerous lesion and the normal lesion, normal area outside the cancerous lesion. So both they will contribute to the prediction. So I think because we cover the whole slice, so the heterogeneity was considered even in the prediction. Maybe the heterogeneity across different gene mutations will also contribute as a factor contributed to the prediction accuracy. Maybe I have one question for Dr. Matthew, because you have mentioned about the tissue quality, because the time consuming and the cost maybe will be improved by the techniques, the advances, like we could take less time and less expensive techniques to do the genomic testing. But if we cannot get sufficient tissue, so it's not available to get the genomic results. So if we could predict the mutation using the slice, using the histological slice, so at least we could have some indication which targeted therapy we could use. But how to persuade the insurance company or the policy to let this happen? So just mention.
Yeah, I was thinking about that also. Yeah, the lack of tissue or good sample size, it's a real problem. So with what you're doing, that could really help. The affordability, almost all of the obstacles Matthew addressed. If this continues to show promise, then that could really be a game changer for making it affordable and having even just a tiny bit of, sample size to be able to make those indications, that, yeah, looks really exciting.
Yeah, I think, liquid biopsy is another available tool when the tissue is not available. And I think any additional tools that we can develop to help us understand the disease better are going to be highly important. And we need to be open to new technology and figure out how to rigorously develop it. So I think it's promising.
Okay, thank you very much. If there are no further questions or comments, we come to the end of this session. I would like to thank all the presenters and also Dr. Wclc for participating by Zoom. I think we had a very interesting presentation, interesting discussion. And I would like to remind you that this press briefing has been recorded and you can view it again on the ISLC YouTube channel. So if you're interested in the biomarkers, pick up a flyer over here and join us tomorrow at 10:05 for the first of 2 presidential symposia press briefings. So enjoy the conference and also our 50th anniversary celebration. Thank you.